Hi, everybody. This is the recording of the lecture from when I wasn't there on Friday the 7th. It's respiratory. And that's our next topic. We finished, and I will be also including, after you look at this, I'll also be sending separately the review recording for the exam, which is scheduled on the 17th, a week from tomorrow. So I'll make sure I get that to you. And here's where we go from this. Hopefully there'll be no interruptions. There's a dog who's looking earnestly outside early this morning looking for a fight. He's looking to bark. Nevertheless, okay, this is the respiratory system. We're going to look at the anatomy. Basically, physiologically, it's there's not as much anatomy in this as you think. There's a whole lot of physiology in this thing. And yes, it's coupled to circulatory. That's where we look at it. It plays a role in all these other things. Effectively, it's fairly straightforward. I mean, I've been framing it this way for forever since I've been teaching it, in with the good air, out with the bad. Basically, that's it. That's what it does. And the terminology sometimes is confusing. To me, it's all you talk about cellular respiration. That's oxygen and carbon dioxide and waste product nutrient exchange at the cellular level. And pulmonary respiration is in the lungs. They have different terminology here, which we'll see. So they call it ventilation here. Fine, you're in and out. I don't know that external is such a great way to express that. I just think pulmonary respiration would work as well. I think that's a little confusing. And then obviously the circulatory system is a transport mechanism, and they call it internal respiration. To me, that's cellular respiration. So, I mean, if that's confusing to you, I'll try not to make it so. That's the terminology that I prefer to use. And you can see it here, what we have. Okay, effectively, and it's coupled so well with after we were talking about coming after the circulatory system. There we have the pulmonary artery and the pulmonary arteries that divide, going to the lungs for the exchange. We bring the oxygenated blood back to the left side of the heart, systemic circulation, and then the cellular respiration's on that end of it. Okay, we're good. I mean, pulmonary ventilation, breathing would strike me as being a much better word for that, but it's the way it is. This is what we're looking at. You have and understand we have basically a divide. There's both structural anatomy and functional anatomy. To me, upper and lower are better terms when we talk about the functional anatomy. And effectively, the decision has always been, where do we put the larynx? I mean, and we can go with this and call basically the nose, nasal cavity, the sinuses, pharynx, your throat, upper respiratory. When we anything after that basically is lower respiratory. I've taught this from a variety of different textbooks, and a lot of times the larynx will be this overlap that's there. Why is this important? The most common diagnosis we see, and you've all seen it before, when you've gone to the doctor, you've gone to a health service, you've gone to URI, upper respiratory infection. To me, it's kind of where it starts, the distinction between upper and lower respiratory infections. Because a lot of times you'll have an upper respiratory that'll give you laryngitis. That's that. It's kind of where it starts to me when we define those infections. I know that's off topic, but I thought it would be interesting just to mention it. When something start with laryngitis, and the next thing you know, you have bronchitis and possibly even pneumonia, something terrible like that. That to me is a true lower respiratory infection. To me, it's kind of where it starts. But for the time being, we'll utilize this and consider this the larynx is the dividing line. Anything larynx and below, lower respiratory versus upper respiratory. To me, that's more of the functionality with regard to it. I've seen those models 100 times. There's not a lot to it. How long is this thing? Foot and a half. But again, the magical way that we see all of the divisions of the bronchi and all of the structures and how small they get really points out this massive amount of surface area. And this again is the two-edged sword of anatomy and physiology. We have this brilliant anatomy, all this surface area, and the reality is, and I've said it to you probably before, is somebody who's had respiratory problems and smoked and whatever, been in an occupation where they've had a lot of exposure, and all of a sudden they go to the doctor with they've had a series of bronchitis. They go there and they go, look, you're going to have to be on oxygen for the rest of your life. But why now? And when I was here a year ago with the same thing, I didn't have to do that because it's like flipping a switch. Once it gets to be 75 to 80% gone, all of a sudden now you've gone from an acute respiratory problem to a chronic respiratory problem like chronic obstructive pulmonary disease or emphysema. And all of a sudden now you have to bolster the amount of oxygen. Go figure, it's crazy. But anatomically speaking, we have the nasal cavity, and there's a nasal cavity is bigger than you think. And behind it, you have the pharynx. And the pharynx has three divisions. Classically, we see this again in digestive. The naso, the oro, and the laryngopharynx is relatively small, but effectively that's your throat. Then you have a certain degree of complexity surrounding the larynx, technically is your voice box. That's really the vocal cords and things. And I don't do that anatomy because I'm just not great at it. But the cartilages that engulf it are really important. And then you get the trachea, more cartilage, and the bronchi themselves. The lungs themselves are really interesting. It's really, you have these tubes that go less and less and less and less over time. These tiny tubes get smaller. They start large and get smaller and smaller. We're going to see that depending on when you listen to this. You'll see that when we do or have seen it when we do the sheep dissection of the sheep lung heart combination, we call the pluck, Pluck. I don't know why. And the anatomy of the lungs. And we'll look at all of this. The big deal here is this is all hyaline cartilage that you're going to see that really, and that's what gives it a sufficient amount of rigidity and a certain degree of flexibility, but keeps it open. And the term we use for open is patent, Patent. You have to get used to hearing that terminology. And it's all about the cartilage. When the cartilage begins to disappear, all of a sudden it's a lot harder for patency. I have a good handout about this. And that's really, again, where is breathing controlled and where do we get into problems when we get into those tiny microscopic tubules that have less and less, almost no cartilage, and they're called bronchioles. And you'll see the distinction as we move forward anatomically with this presentation. So as we move on with this, and this, these are fine. We'll go into all this, what it does, nasal cavity, and we'll go over this again in physiology, warms, moistens, filters, resonance chamber for speech, sense of smell. Again, same deal here. The cavities, almost like resonating chambers. And then on the pharynx, passage of air and food, and all of this. And I mean, there's lots and lots of immune implications here, but that's for a different talk. And you can see as we begin to get down, this is what I mean. You're going to look at the three major cartilages that are here. We're going to look at the rings of the trachea. We're going to look at how these divide and effectively how it impacts the development of the lungs and the formation of the lungs. And finally, where the exchange takes place, after branches and branches, is this neat thing called alveoli. This is a cluster of alveoli, which are those little sort of grapes. And that's why I always call them grape-like clusters. And they're basically just membranes. All they are, when you get down to the individual alveoli, they're just lining cells that have opened up and the air can pass into them. And you'll see what happens. And they're surrounded. Each level that this branches is surrounded by blood vessels. That's the uniqueness of the pulmonary circulation. Blood vessels, as these divide, we get branching, and we get branching of the pulmonary vessels. The pulmonary artery divides arterioles, and finally they're enveloped here by a capillary bed. And so effectively the lung, and when you feel a lung, it's squishy. It's membranes and air and tubes and blood vessels, and the only rigidity, such as it is the limit as we get down here. These are just noticeable little areas in there. You'll be able to see it very nicely. I'm glad it's sort of, we put the two of them together this way. So we move on, upper respiratory, the nose. I think it's external, airway. Read all this if you want. Very straightforward. I don't do this anatomy. Yeah, the root of the nose is really, and the bridge of the nose, that's really, if you want to think of the root of the nose, where it comes out between your eyebrows. And effectively, when you break your nose, it's the nasal bone. Okay, everything else is cartilage that's there. And you have all of these things, nasal and frontal bone superior, we form the bridge and the root. That's typically a broken nose. And you can see the maxillary bones play a role, but everything else is cartilage, cartilage, cartilage. Don't worry about this. We're not going to look at that anatomy. This is the point. So again, a lot of times when you see somebody with an injury to their nose, they look much more distorted than they are. The break is here if it's broken, but the cartilage can be pushed from side to side fairly easily. You see that a lot in football players. I'm thinking of Ben Roethlisberger. That nose got moved around a lot over time. But you don't have to know the names of any of these cartilage and things. And remember, the septa is cartilaginous. When you start looking at the septal cartilages, which are in there, and as we go farther back, remember you have two bony processes, the vomer and the perpendicular plate of the ethmoid bone that are there. And again, I'm not going to re-ask you the bone questions again. So the septum, the cartilage, and here's the vomer and the perpendicular plate. They're just that. So you have a cartilaginous portion and deeper a bony portion. And then you have all these openings in there and all the stuff that forms it, and it's not important. Nose hairs, we'll come back and look at this vis-a-vis physiology and the different kinds of mucosas. You might guess you have ones for smell and then ones that are more associated with respiration. And this is where it starts. The single most important part to recall for this, because it's certainly on the test, is pseudostratified ciliated columnar epithelia. That's the big player. That's the core lining cell of the respiratory system. And so that's really important. And they all have goblet cells. And you'll see digestive is very similar in that regard. Goblet cells make mucus. And so this is where we see mucus, respiratorily and digestive, by the way. So again, different types of glands, mucus cells and serous cells, blah, 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 the cilia. We're going to go over this as physiology and all what happens with it. I don't really care about the conchae, the superior and middle. Right? And these are all the things that give surface area, by the way, that are there. These are really associated where if you go back and look at the ethmoid bone, the superior middle conchae are really the bony, and then the soft tissue covers it. And the inferior is that one that's for some reason a bone by itself. Not a big deal there, and all the things they do: filter heat and moisten, reclaim heat and moisture. So nose is really important. You breathe in through your nose and out through your mouth, typically. But you could obviously we can do all of that differently. But typically, the nose is as much in and out as anything else. The sinuses themselves, anatomically, there are 4 paranasal sinuses. I use the acronym FEMS: frontal, ethmoid, maxillary, and sphenoid. However you want to do, and again, they play a similar role. The trouble when we get into the physiology and the trouble, which I don't know whether you covered in micro or not, they're like blind chambers. They're cul-de-sacs that emanate. And the problem with those emanating those cul-de-sacs is they effectively become ways where infection can get trapped. They're filled with fluid, with a viral infection, a fluid. If there's and basically viral infections lead the pathway for bacterial infections. Next thing you have a bacterial sinusitis, and now it can go in any direction. Because there's another passageway that's a lacrimal duct. It can go up to your eye and lead to conjunctivitis, more frequent in adults this way, as opposed to children where they rub their eyes. And then, of course, it can lead backwards by the large passageway, okay, the pharyngotympanic tube, the auditory tube, the eustachian tube, all the same tube. And basically, that's that passageway we looked at when we looked at the ear anatomy. And now we're looking from the respiratory. And that's where we get ear infections in kids. And remember, I mentioned to you the big problem, and it's an anatomical basis of disease, things I love. And the anatomical basis of disease in this particular instance, remember that in children, it's very horizontal. So when a baby sleeps on its back, it's draining directly back toward their eardrum. As opposed to after roughly age 4, somewhere depending on development, let's say by age 4, now it's much more declinated. It's pointing much more rather than being horizontal. I may have said vertical mistakenly before, but rather than being horizontal, now it's become more vertical and declinated, sort of angled down, and that's why we don't see those kinds of infections in adults. And they're showing you here the openings for the sinuses that are there and the auditory tubes here. Those are, again, you begin to see those neat little you know, that's an adenoid, by the way, and the tonsils are slightly differently located. Not important. And inflammation, sinusitis, blah blah blah. Behind it is a pharynx. It's a funnel, but it's opened anteriorly. It's three muscles, which are called pharyngeal sphincters, that basically, and they're muscles we control because they swallow with them. And as you can see, they run from the base of the skull, roughly in the cervical area, almost down to C8, but to C7 rather, but to C6, that are there, skeletal muscle, and it creates those areas, and we define them for what they're behind: the nasopharynx, the oropharynx, and the laryngopharynx. And you can see this. I'm listening to see if it's a cat. I might have to do something with it, but we'll be fine. And you can see pseudostratified columnar epithelium. The only area where it changes is in the mouth. Yeah, that's a cat. Okay, and in the mouth it goes to stratified squamous, non-keratinizing, and then we go backward, and you can see the adenoids are there, the auditory tubes, etc. We'll stop it here and rejoin. Sorry for the interruption, but cats are particularly annoying when it demands to go out. Anybody like a cat?